Hi guys, welcome back. The next topic that I'm going to teach you has been asked for 10 consecutive years in the NEET PG exam. It has been asked for 10 consecutive years in the FMG exam, and because the FMG exam is conducted twice a year, that would make it 20 papers where consecutively the same topic of pneumothorax has been asked. Even in the INICET exam, they're going to give you this X-ray, but they'll ask you the treatment and not the spot diagnosis. But I would at this moment like to sensitize you to the fact that out of the three pneumos, that is pneumothorax, pneumoperitoneum, and then pneumomediastinum, usually in the exam, at least one or two of these would be asked. In this video, I'm going to cover two of them. That's going to be pneumothorax and pneumomediastinum. So let's get started. In this X-ray, you can see the left side and the right hand side. On the left hand side, we can pick up the lung vasculature. We can see these pulmonary blood vessels. But on the contralateral side, what we can see is a collapsed lung, and the remaining area looks much more black as compared to normal. So where I'm doing a bit of marking and where I put in a plus sign, what I'm trying to say is that on this particular side, the lung appears more black than normal. The reason for that is air at positive pressure that's present in the lung fields in a case of pneumothorax. And therefore, your technical answer for diagnosis of a pneumothorax on an X-ray would be absent lung markings. The vascular markings are absent, even the lung parenchyma is not there. All that is present here is air in the pleural cavity. Meaning of the word pneumothorax is air in the pleural cavity, and this air is at positive pressure. So this can compress on the same side lung as well. It will cause collapse of this lung. In fact, this air at positive pressure can gradually build up and can compress the superior vena cava and inferior vena cava, compromising the venous return of the heart. In fact, it will compress the venous return of the heart, so therefore the BP can crash, and therefore the condition that will evolve in our case would be called as tension pneumothorax. Tension pneumothorax is always to be answered whenever there is words written like crashing patient, unrecordable BP, hemodynamic instability. There are a couple of other features also that I'll explain to you, but one of the main things is look at the blood pressure values. In tension pneumothorax, the blood pressure would be crashing and outrageously low blood pressure values would be given, 70/50 or 60 systolic, and the diastolic is not recordable. And the X-ray findings that you will encounter would be a jet black lung. There would be absent lung markings, and along with this, as I said, the X-rays, obviously you can argue, sir, X-ray is already black, so what's the big deal? Here I'm saying it's more black than normal because there is air at positive pressure. So therefore, the radiological term is absent lung markings with radiolucent lung. On the right hand side identifies a right-sided pneumothorax. Now, if we compare this with the image on the contralateral side, the image that I put an arrow at the moment, you will notice that this particular person was not able to sit up in the hospital bed, or he was not able to stand up because he was very sick, and therefore we decided to do an X-ray in a supine position. In a case of pneumothorax, when you're going to be doing an X-ray in a supine position, this is a rotated film, that's okay. Patient may not be lying straight, but I would like you to compare the costophrenic angles on the two sides. And what you're noticing on this particular side is taught by the radiologist as well. That's again a very good pickup point for multiple choice questions. That would be called as deep sulcus sign. In pleural effusion, I've told you blunting of the costophrenic angle. Here I'm saying the CP angle is more deeper than normal. This is where the air would be accumulating when the person is in supine position. So the radiological term is deep sulcus sign. Over and above this, what you can also see is this ipsilateral collapsed lung. So this is a routine X-ray, but if they give a digital X-ray, then you will be able to see a very clear line of the pleural reflection as well. The visceral pleura would be very clear. In this case, all I can say is that there is a collapsed lung which is appearing white, and then the contralateral side is more black as compared to normal. There is no vascularity, and the deep sulcus sign is present. However, to be able to see a deep sulcus sign, the patient should be in a supine position. Then another question that has been asked on this topic from the radiology perspective, traditionally I start with, the clinical details and go on to X-ray. But clinically speaking, tension pneumothorax, tension pneumothorax per se is a clinical diagnosis. Especially if a soldier is having pneumothorax due to a bullet injury to the chest, or if it is occurring due to a stab injury to the chest, this would be a clinical diagnosis, and you may not have access to an X-ray, especially outside. I mean, in a hospital setting, things are different, but I'm saying in a battlefield scenario, if a soldier has developed pneumothorax, then tension pneumothorax specifically, then that would be answered by you as a clinical diagnosis. In a battlefield, obviously, chest X-ray would not be available. Once the patient is brought to the hospital, all these findings will become very, very clear. And from the radiological perspective, he decided to ask regarding lights index. Now, a lot of guys who sat for the exam told me that, doctor, we thought that this was lights criteria, and they did not read the question carefully. And sometimes, in fact, I can say more than 50% of the time, no, we make silly mistakes in the exam. Lights criteria are for pleural effusion. Lights criteria are used to identify whether the pleural effusion is a transudate or is it an exudate. So I've described lights criteria per se in the video pleural effusion, which is still in the pulmonology section. You can go through it. Maybe if you've come directly to pneumothorax, you can go to pleural effusion section subsequently. But if he says what is lights index used for, then your answer is not gonna be pneumothorax. I mean, your answer is not gonna be pleural effusion. Your answer is not gonna be hydrothorax. It's gonna be pneumothorax. And well, lights index technically is used to determine, sometimes we say words like small pneumothorax, large pneumothorax. Then small and large is very subjective. So technically lights index is used to calculate the percentage of pneumothorax. I mean, it is used to evaluate how much percentage of the lung has been affected in this particular case, or I can say it is used to gauge the severity of damage that has been caused to that particular lung due to this lung pathology called as pneumothorax. The total of 3 points from radiological perspective on this slide, which I would like to reiterate. One is absent lung markings and radiolucent lung. If it is supplemented by, he is himself telling you right in the beginning, absent lung sounds. If he says absent breath sounds, that again is an auscultatory finding, which is very characteristic for pneumothorax. Then he says absent lung markings or gives an X-ray like this, and also says that the BP of the patient is crashing. You will think in terms of tension pneumothorax. In fact, that's the usual scenario that is given, and you would manage this patient by putting a wide bore needle in the fifth intercostal space, following which the chest tube would be inserted in the triangle of safety again in the fifth intercostal space and attached to underwater seal, and you would have recovery. You will be able to prevent death in these patients. Let's now focus on the pathophysiology of development of pneumothorax. So this time I can say this part of the video I would like to dedicate to a warrior. You can Google his name also subsequently after you listen to this. This guy was a commanding officer of a CRPF unit which was fighting Lashkar-e-Taiba on 14th of February 2017. I mean, the whole world was celebrating Valentine's Day. These guys were in encounter with Lashkar-e-Taiba, and Chetan Cheetah, the commanding officer, he took 9 hits. I mean, that's, he got caught up in a Kalashnikov rifle burst and he got 9 hits, but he kept on fighting valiantly till he neutralized the terrorist and survived those 9 hits. So you can understand he sustained bullet injury to the chest also. So let's look at, from example of Chetan Cheetah, what would he have gone through once the bullet went into his chest. Now, every time there's a penetrating injury to the chest, you see in the atmosphere, the atmospheric pressure is about 760 millimeters of mercury. If you contrast this with the pressure in our pleural space, the pressure is going to be in negative. It is usually between -4 to -6 millimeters of mercury. So I can overall say that there is a huge pressure difference between the atmospheric air, that is 1 atmospheric pressure, and the intrapleural pressure. Now, if there's going to be a penetrating injury to the chest, the moment the bullet will enter into the chest, usually it creates a tissue flap. Most of the time, whenever there's a penetrating injury to the chest, it can result in development of creation of a one-way valve. The tissue or the bullet entry creates a tissue flap which acts like a one-way valve. And what I mean by one-way valve is that it will allow the air to go into the chest, but will not allow the air to exit. To explain this, I can say, like when you fill air in the tire of your car or when you fill air in the tire of your bike, you notice that the air goes into the tire. It doesn't come out unless and until you are having a faulty valve present there. So what I'm trying to say is that every time there's a penetrating injury to the chest, there's a one-way valve created which will allow to air to continuously go in the chest, and therefore the pressure in this area will start turning positive, and it will start squeezing on the lung from outside, and therefore what you're going to have is a collapsed lung. At this moment, what I've tried to show is that there is air at what the plus signs now are showing that the lung on this particular side is collapsed, and at the same time there is going to be air at positive pressure, which is also going to be putting pressure on the superior vena cava and the inferior vena cava. We have great veins present here. The great veins are like superior vena cava, inferior vena cava, and due to the positive pressure here, the superior vena cava and the inferior vena cava will get kinked. Due to the kinking of the SVC and the IVC, the venous return to the heart will decrease to almost 0. And if you do not have any venous return to the heart, the BP will crash. The condition that we're discussing at the moment is also described in the cardiology section as an example of pulseless electrical activity. Let me just retrace the steps that I just taught you. The topic that I'm going to teach you at the moment would be tension pneumothorax. So I'm just going to write it as T, which implies the tension pneumothorax part. And one of the characteristic features of tension pneumothorax, apart from mediastinal shift, would be crushing of the blood pressure. In fact, tension pneumothorax can also be asked in the exam as an example of obstructive shock. I said why obstructive shock? Because the air at positive pressure, the air is continuously going into the chest via the bullet injury site. Or instead of bullet injury, he might be mentioning, instead of a penetrating injury or a bullet injury, he could talk about like a stab injury to the chest. Like a couple of young guys, they went to a discotheque and they had a fight with a bouncer, and lots of times these bouncers are rowdy people, so they stabbed him in the chest. So every time you have a penetrating injury to the chest, it's going to create an open pneumothorax, that's okay. But the tissue, the tissue flap that is created in this place of the site of injury acts like a one-way valve and allows air to go inside, crushes the superior vena cava and the inferior vena cava. Therefore, the venous return to the right side of the heart will almost become zero, and therefore the blood pressure of this person is crashing. The last time I described obstructive shock to you was in cardiology. The last time I taught you guys obstructive shock is seen in, I was teaching you cardiac tamponade. You can go back to the discussion of a car crash where a guy is driving a car without a seat belt on, his chest slams into the steering wheel, he gets a hemopericardium, and the blood which is accumulated in the pericardial space is squeezing his heart from outside. So cardiac tamponade is usually a scenario which is that's where I've described obstructive shock, and today I'm describing again tension pneumothorax as a cause of obstructive shock. So there are two causes that you need to understand, and because in these patients the heart is still beating, the problem is not per se with the heart, there's no failure of electrical activity, there's no cardiac arrest, but still the pulse is disappearing. Traditionally pulse will disappear when the heart stops beating. Here the heart is beating, but still the pulse is disappearing. Why? Because in these patients, the superior vena cava and the inferior vena cava are crushed, and therefore do not be surprised that he says the word pulsus paradoxus in literature of tension pneumothorax. You read about pulsus paradoxus with cardiac tamponade, you read it with constrictive pericarditis, but today I'm teaching you that apart from cardiac tamponade and constrictive pericarditis, you need to remember respiratory condition also. Tension pneumothorax can also be having pulsus paradoxus. Due to the pressure on the SVC, if you check out the JVP of this person, the JVP will always be increased. So therefore, in large number of these questions on pneumothorax topics, obviously lung findings will be given, but then cardiovascular findings will also be described in the form of pulsus paradoxus and elevated jugular venous pressure. On casual reading, you might start thinking in terms of a cardiac tamponade, but then for cardiac tamponade, he must mention regarding findings of Beck's triad, muffled heart sounds. He should talk about ECG findings like low voltage ECG, electrical alternates. There would be no mention of information like this. And in fact, he can rather to help you with the diagnosis that this is tension pneumothorax, because there's going to be air at positive pressure. It's also going to cause displacement of the heart. The displacement of the heart will always occur to the contralateral side, just like the trachea of these patients will also be shifted to the contralateral side. We will be getting a contralateral tracheal shift, though that's a late finding, but still is very much present. Contralateral tracheal deviation is present. Even in pleural effusion, there's a contralateral tracheal deviation. Even in pneumothorax, there's going to be even if it's a routine, tension pneumothorax, whenever it's present, you will always say contralateral, and every time it's going to be spontaneous pneumothorax, then it's going to be ipsilateral. But at the moment, because our focus is on the more severe variety of the disease, where you have to put in a wide bore needle. So remember that pulsus paradoxus, elevated JVP, and apex beat displacement will be given, whereas the term that I'm currently writing, apex beat displacement, is not present in tamponade. In tamponade, rather, it would be a hypokinetic apex, or you may not be able to feel the apex beat at all because of the fact that heart is surrounded by a bag of fluid which is crushing the heart from outside, and therefore the blood pressure will begin to fall. So apart from auscultatory findings, because in this particular case where I put the plus sign here, there is no lung. So in the MCQ to help you, obviously he has to mention this, that there are absent breath sounds. So I'm not saying that only you would be left to fend on the basis of pulsus paradoxus and elevated JVP. He's going to mention about absent breath sounds, and this terminology is not given in cardiac tamponade. So if you put the whole thing together from the pathophysiology perspective, this brave warrior from CRPF took a hail of bullets from the AK-47 rifle of a Lashkar-e-Taiba terrorist, and he collapsed. Then the army medic would have taken care of him, and they ensured that he survived. I mean, they put a chest tube in his chest in the battlefield with bullets flying around. Imagine diagnosing pneumothorax, and then they put a chest tube in his chest. They initially would have put in a wide bore needle, and they were able to save life of Chetan Cheetah, and he endured, I mean, the entire thing. But what happens every time you are having a tension pneumothorax is what I tried to explain to you here. The MCQ will deliberately in the beginning itself mention regarding pulsus paradoxus and elevated JVP. He wants to misguide you and start thinking in terms of a cardiovascular presentation. Yes, the heart is getting involved in this condition, but in what sense? There is no fluid outside the heart, there is no blood outside the heart, there is no lung cancer which is causing a malignant pericardial effusion. What's happening here is apex beat displacement that will be occurring to the contralateral side, in a sense that suppose the injury is on the right hand side, then the apex beat will be pushed more towards the left. I mean, apex beat traditionally is like in the fifth intercostal space, 2 centimeter medial to the midclavicular line. Here he might be rating apex beat in the midclavicular line, or it might be pushed even beyond the midclavicular line. I'll repeat that again. You're aware from anatomy that our apex beat is not exactly in the midclavicular line. It is 2 centimeter medial to the midclavicular line. Now it's gonna be displaced. So he will write apex beat at the midclavicular line, and he will say which of the following is wrong about this condition. So apex beat in a normal person, I mean per se, pneumothorax, there's gonna be from in a normal person, you are not gonna have an apex beat in the midclavicular line. It would be medial. Right. So if you're saying that apex beat is in the midclavicular line, it means there's a displacement of the heart, which is a cause of concern. And apart from that, tracheal shift would be also present to the contralateral side, though this tracheal shift occurs a little later, and therefore you need to focus on the data that I mentioned: pulsus paradoxus, elevated JVP. In fact, two small sign can also be present here. That is, the JVP will not fall with inspiration. Normally, whenever we take a deep breath, JVP should fall with inspiration. Here it will not fall again because the great veins are crushed. The SVC IVC are crushed, and that is why JVP is elevated. There's an apex beat displacement with the key word absent breath sounds. Having said that, now let us focus on the clinical findings that would be seen in these patients. So why is a pneumothorax patient brought to you? There would be breathlessness even at rest. There would be chest pain that would be experienced. This would be because of the involvement of the pleura as well. Then moreover, you will also notice that person will be having anxiety, or there might be a mentation of the person can be affected. He might not be in a position to recognize his platoon members, or he is not able to recognize his junior commanding officer. The mentation is affected primarily because of severe hypoxia. So at this point of time, majority of the time, because the person is becoming unconscious, there would be severe hypotension. The blood supply to vital organs is getting compromised, which is why the mentation of the person is affected. And since BP is less, I said that can affect the coronary blood flow as well, and that is why chest pain can also be explained. The primary reason for chest pain would be the injury to the chest, plus there is involvement of the pleura also, so pleuritic chest pain. And then more importantly, because of the hypoxia component, anxiety and mentation will also be affected. Now when you are going to examine this person, you cannot maintain oxygen saturation with one normal lung. Like this guy got hit on the right hand side, and therefore only the left lung is working fine. So with one lung, the oxygen saturation cannot be maintained normal. So no big deal. The lips will start turning blue, or they might be not written like blue or cyanosis. You might say dusky discoloration of the lips and fingertips is noted. That would be central cyanosis. That explains the subsequent development of hypoxia. The person will be breathing as if he's run a half marathon. His respiratory rate would be increased. Values like 40, 50 might be given. Along with that, mention of accessory muscles of respiration, like traditionally accessory muscles of respiration would be used whenever person is doing very severe or very hard workout in a gym, or like a person is doing marathon running. But in this particular case, accessory muscles of respiration would be visible, though the person is lying in the hospital couch in the casualty. Sternocleidomastoid, Allen Azai, then scalenus group of muscles would be visible in the base of the neck. Flaring of the nostrils would be present. So it would appear as if this guy is in a lot of distress. Then as far as the tracheal position is concerned, I've already explained to you that this is a late finding, and lots of time do not try to diagnose a pneumothorax on basis of a tracheal position or the type of pneumothorax on the basis of tracheal position. Lots of guys try to do that. It was contralateral, it was ipsilateral. I already told you contralateral in tension, and in spontaneous it can be ipsilateral as well. So I mean, you cannot comment on tension pneumothorax on the basis of tracheal deviation, because if you are thinking it's a tracheal deviation, first of all, I want to say for tracheal deviation, you ideally need a PA view. And in emergency, you would never get a PA view. Now the person will be sick, so it will always be an AP view. Like if you're doing X-ray in a supine position, it would be an AP view only. So do not try to diagnose pneumothorax. Tracheal deviation may or may not be present. In fact, it's in fact a late feature. The main feature that would help you pick it up in an X-ray would be that jet black lung that I was explaining to you, the translucency in the lung, the absence of the vascular markings, the deep sulci sign. That is how you pick up a pneumothorax. Then apex beat of the patient would also be shifted to the contralateral side, and then comes pure hardcore respiratory findings, that because there is gonna be collapse of the lungs, so therefore vocal fremitus will be reduced. When you're gonna do percussion in the chest, every time there is a pleural effusion, you always read about stony dull because there's water over the lung. So you read about stony dull percussion note. But today, because there is air at positive pressure in the chest, so I'm using the word hyper resonant percussion note. That would be one of the key words in the question that would let you know that he wants answer as pneumothorax. Apart from this, when you will auscultate on the side where the injury is present, on the side that there is a pneumothorax, there would be ipsilateral reduced air entry. Now, when I'm writing point number 7, you will notice that point number 7 is described even in pleural effusion. In pleural effusion, there is water over the lung. Here, there is a lot of air that is squeezing on the lung. So, ultimately, in both of them, there would be a reduced air entry or can be absent air entry. But the point is, because this finding is common with respect to pleural effusion, then what should be written subsequently in a question that you know that you are not dealing with a pleural effusion and a pneumothorax would be this word absent/distant. I'm saying distant because if the lung is collapsed, if whole of the lung is collapsed, then there is no breath sounds. If some part of the lung is still very much functioning and the remaining, let me say only 50% of the lung is working at the moment, the remaining 50% of the lung is totally collapsed. So because of the fact that 50% lung is still working away from the chest wall, so he might say distant breath sounds. Traditionally, I have taught you distant heart sounds with respect to cardiac tamponade. I've taught you distant heart sounds with respect to cardiac tamponade and massive pericardial effusion. But today I'm teaching you distant breath sounds. Why? Because the lung is not close to the pleura. The lung, in fact, the visceral and the parietal pleura, they're hugely separated because there is air present in that area. Normally the visceral and the parietal pleura would be in close adjacent proximity to each other. There would be pleural fluid for lubrication purposes. Now both of them are grossly separated because there is air present there. As a result of it, what you have is some part of the lung is still functional. So I said distant breath sounds. If the whole lung is collapsed, then there would be absent breath sounds. But then you need to understand point number 7 as one of the key words written in a question. Every time you read a question that says ipsilateral reduced air entry and says stony dull percussion note, mark my words there, ipsilateral reduced air entry, and he says simultaneously that there's going to be a stony dull percussion note, your answer is pleural effusion. If he says ipsilateral reduced air entry but he says hyper resonant percussion note, it would be pneumothorax. And to aid you, he will also mention regarding the breath sounds. Over and above this, I can just say, generally speaking, guys, that if it's pleural effusion, no, pleural effusion is water. So if you will change the position of the patient, like if you depress the head end of the patient, then fluid will tend to gravitate towards the apex. If you make the patient sit up, the fluid will tend to gravitate to the bottom. So what I can say is that because there is water over the lung, if you change the position of the patient, the findings can change because the fluid will get mobilized. Unless and until it's like a loculated effusion, then it's a separate issue. But if there is no loculations present, the fluid will change its position with change in position, and therefore the auscultatory findings can vary, but that would not happen with respect to pneumothorax. Apart from this, because our case will also be having a pneumomediastinum, and they have asked this in the exam, what I'm saying at point number 8 is a one-liner MCQ that is called as Hammond sign, or is also written as Hammond crunch sign. In fact, Hammond sign is because of the air dancing around the heart of the soldier. So it's like a crunch, like when you bite into a wafer or you bite into a chips per se, crunch sign would be produced. So Hammond sign or Hammond crunch sign per se is an auscultatory finding. It's a crunch sound which is heard, or to describe this crunch, I can say somebody walking on freshly fallen snow with heavy duty military grade leather boots. Freshly fallen snow is soft, and when you walk on that snow, like patch, 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 the sound would be created. Or like I said, biting into a chip per se, or wafers per se. So Hammond crunch sign is an auscultatory finding. This crunch is gonna be synchronous with the heartbeats. And this is again important aspect with respect to multiple choice question, that this would be an auscultatory finding. I mean, this was the question one liner, that Hammond sign is a feature of, and your MCQ answer would be pneumomediastinum. For pneumomediastinum, there is no need for, in majority of cases, there is no need for putting in a chest tube or any drain. In majority of cases of pneumomediastinum, all you require is high flow oxygen, and this air which is present will get reabsorbed. That's a separate issue, that pneumomediastinum is occurring due to rupture of the esophagus and there is spilling over of the esophageal contents also into the chest cavity. Then we might have to, go in for surgery and put in a drain. But otherwise, pneumomediastinum in majority of cases will respond to high flow oxygen. So point number 8 is supportive evidence. I'll explain the core aspects once again. Guys, if you get an MCQ in which he only mentions ipsilateral reduced air entry, check out the percussion finding. If the percussion finding in the MCQ states stony dull percussion node, think in terms of pleural effusion. If he says hyperresonant percussion node, think in terms of the topic of interest, pneumothorax. Plus, he will always assist you with auscultatory findings, that is absent breath sounds. In pleural effusion, you will never have absent breath sound. Distant could still be present because there is water over the lung, but this word absent breath sounds again is, as I mentioned even in the previous slide, is one of the dead giveaways in a question that tells you, okay, he wants an answer as pneumothorax. So these are like the examination findings. And now let's focus on the treatment that we'll be doing for this patient, because if I'm not going to wait for an X-ray in this particular case who's that sick that his BP is crashing. So let's just add that point here. The description that is given on this particular slide is for tension pneumothorax with the hemodynamic instability. What are you going to do in this case? Your answer would be that we will be putting this. I think everybody knows from surgery that we'll be putting a large bore needle. When you will put this large bore needle into the pleural space, and when the moment the air enters into the pleural space, the air will start escaping from the distal end of the needle, and you'll get a hissing sound from the backside of the needle. Like, there's a, on a pressure cooker, like there's a whistle, no? Like that sound. So that sound would be created because of the air escaping from the pleural space into the atmosphere. That would be large bore needle. Now, obviously, large bore needle is not a permanent solution. We need to put in a chest tube, but the objective of putting a large bore needle is mainly to evacuate that air, which is so much accumulated in the chest that it is crushing the superior vena cava and the inferior vena cava, causing hemodynamic compromise. So if I allow that air to escape, the SVC and the IVC will re-expand. Blood will start going back into the heart. If the venous return will improve, the BP of our case will also begin to improve. This large bore needle should not be removed. It should be remaining in situ before the chest tube is put. And remember, you cannot fly a person who's having a pneumothorax. Lots of time I get queries here, sir, the soldier had been hit by a bullet. Why did you not straight away take him in a helicopter and take him to the hospital and manage him? Why are you treating him in the battlefield area? Then you know that when a plane or a helicopter will ascend or descend, there are pressure changes. It is, airlifting a soldier with pneumothorax is contraindicated. You do not airlift with pneumothorax because that air will expand. It will cause further compression of the SVC, IVC and will cause deterioration. So airlifting at the moment, we might have called in for a medical evacuation. The chopper may be on its way or might have landed, but the doctor in the Army Medical Corps will first put in a wide bore needle and the chest tube and then transport the patient. Remember, untreated pneumothorax is a contraindication for air travel. I reiterate my statement, untreated pneumothorax is both, air travel and scuba diving. Scuba is obviously not the logical thing to talk about here at the moment. But the point is, per se, pneumothorax, if they're untreated, air travel is a big no. So we're going to put a wide bore needle. Where are we going to put it? You know this from surgery. We're going to put it in the 5th intercostal space. Like the soldier has fallen down. Even if he's wearing a bulletproof vest, sometimes the bullets can be of high caliber also. Like the bullet was fired from a very close distance, so that Kalashnikov rifle might have gone through the bulletproof vest also. The point is, bulletproof vest is designed to stop a bullet from a particular distance. If the bullet is fired from a high-powered rifle at a close range, the bullet can go through the bulletproof vest, and I don't have time to remove that bulletproof vest. Bulletproof vest is in the front, bulletproof vest is in the back, but is not on the side. No, so if the soldier will fall down, still you can cover the rib spaces on the side, and you can be putting a large bore needle in the 5th intercostal space, and this would be put in the mid-axillary line. in the current edition of Harrison, he's still mentioning second intercostal space, mid-clavicular line, but we are going by the ATLS guidelines. So I think this would be in sync with what the surgeon has told you. I mean, if you're gonna read this from Harrison, Harrison mentions the fact that you're gonna put the needle in the second intercostal space, but then I would say that at the moment we're dealing with a case which subsequently a surgeon would be handling. So we'll go by the latest advanced trauma life support guidelines, and that is large bore needle in the fifth intercostal space in the mid axillary line. For child it's okay, I mean second intercostal space, but adult he says first answer should be fifth intercostal space by ATLS. Otherwise, if he specifically, like he mentions according to Harrison, then your answer would be second intercostal space. We can't challenge a textbook. And while the needle is in place, we're gonna do the next thing, which is the most important step for saving the life of this guy after putting in a large bore needle, that is intercostal drainage tube. Do not answer plain large bore needle. That's a temporary solution. Again, the air will keep on going back in the chest through that one-way valve that was created due to that bullet injury. And again, the air will fill in the chest, again will crush the SVC and the IVC. So large bore needle is only a temporary solution. The main solution is putting in a chest tube, and the intercostal drainage tube would be put in the triangle of safety. Now, what are the boundaries of triangle of safety will be discussed in the subsequent slide. We'll talk about the anterior border, we'll talk about the posterior border or the posterior boundaries of the triangle of safety, but the chest tube is again put by default in the fifth intercostal space. Where would you put it? You will usually be putting it anterior to the mid-axillary line. And here again, I know that, the surgeon will say anterior axillary line. Some books will be saying mid-axillary line. So here I am saying another way that some books are describing it, that instead of saying anterior axillary / mid-axillary, they're very close now, anterior axillary, mid-axillary, he says put it in anterior to the mid-axillary line. So the main message is like wide bore needle in large bore needle, a wide bore needle in the fifth intercostal space mid-axillary, and the chest tube again in the triangle of safety. If he's asking more in detail, then your technical answer is anterior. ANT stands for anterior to the mid-axillary line, and then you will be connecting it to the underwater seal. This underwater seal will prevent the atmospheric air from going into the chest of this patient, and this underwater seal, you will notice that there would be a water column present. That water column will keep on moving. That movement of the water column is called as tidling. I repeat that again. This is itself a one-liner question. What is tidling? So tidling simply means that there is a movement of the water column to and fro. I mean, with inspiration, this water column will be moving more proximal to the chest wall, and with expiration, it will move away from the chest wall. So there's a to and fro movement in the chest. You would have seen that water column keeps on oscillating. That is technically referred to as tidling. At the same time, in this underwater seal, you are also going to notice intermittent bubbling. They've asked in the exam that if there is a continuous bubbling of air, what does it indicate? It means there is a air leak. I mean, the connections are not proper. There is a air leak present. So there is going to be an intermittent bubbling synchronous with respiration. When the person will breathe, you will notice some, bubbles of air that would be escaping. And I'll just show you that underwater seal collection system also. But at the moment, the main data is that for an X-ray that they usually give in the exam like this, the one that I've shown at the moment, which is currently in focus at the moment, and he might say, what is the first line management? Your answer is wide bore needle in the fifth intercostal space, followed by a chest tube again in the fifth intercostal space in the triangle of safety, and we're gonna hook it to an underwater seal to cause evacuation. There would be tidling, there would be intermittent bubbling, and not a continuous bubbling. Continuous bubbling is always suggestive of an air leak. Let us now focus on a mnemonic that helps us remember these findings. And this mnemonic for tension pneumothorax can be remembered by the name of death. Tension pneumothorax can contribute to development of death. So the first entry to be remembered in this mnemonic is that there is going to be a decreased air entry in the chest, and instead of writing decreased air entry, he might even describe vocal fremitus. So the first message is that because tension pneumothorax is a life-threatening condition and can contribute to death in a person, that is why we have to remember that it would be a decreased air entry. The second aspect would be absent breath sounds. Instead of mentioning absent breath sounds, as I've explained to you, some MCQs might even say the word distant breath sounds. Then would be tracheal deviation. For tension pneumothorax, the tracheal deviation would always be occurring to the contralateral side. And then we come to the H of the death mnemonic, that would be hyperresonance. As I've explained, every time there is going to be pleural effusion present, there is going to be presence of stony dull percussion note. In pneumonia, it is dull. In pleural effusion, it is stony dull. But in this case, because of air at positive pressure, there would be hyperresonance to percussion. So let's do a quick recap of death. There is a decreased air entry, decreased vocal fremitus. Absent breath sounds in a patient slash, as I explained, distant breath sounds. There would be tracheal deviation to the contralto side and hyperresonance to percussion are some of the key words that have to be identified in a question to identify this topic, followed by the intervention that I've explained to you. Next, in this image, you can check out the intercostal drainage tube, and then it would be put in the triangle of safety. So the anterior border of this would be pectoralis major. And when it comes to the posterior boundary of the triangle of safety, then this muscle in the back, which is also useful for swimming, it is also responsible for climbing, would be answered by you as latissimus dorsi, and that will form the two boundaries of the triangle. The anterior one, I repeat again, pectoralis major, the posterior one is latissimus dorsi, and then the base of the triangle would be formed by the fifth intercostal space, and this is where the chest tube would be inserted. Then what you can see is the underwater seal collection systems which are present here. So in these systems, they can ask you whether it's a dry system or whether it's a wet collection system. Well, how would you answer this underwater seal collection system? I mean, this is where, like, let's say hypothetically, there is blood in the chest also. And obviously because of bullet injury, there would be blood also, there would be air also. So this is the collection chamber. This is where the blood will be accumulating. And then there is going to be air as well. So this air will basically move, the air will move across these segments, and then it will be producing this intermittent bubbling here, and finally will be escaping out through the suction system. In fact, this system that is currently shown on the projection before you is having this orange display here, and this orange display is for the negative suction that is created. You have to connect this device to a suction device that will generate negative force, and this negative force will help in sucking out that air which is accumulated in the chest of this patient. This is the connection for the intercostal drainage tube. You can clamp the system as well. You will notice intermittent bubbling present in the column gradually where the air is evacuated, and then I said there is a negative suction as well present. So this would be called as a dry suction system, and the brand name is Atrium. You would have seen this collection bags in your hospitals, and even the surgeon will talk about it. But if they give you an image of this underwater collection seal bag, and you can notice this orange display in which pressure values are also written -10, -20, that means it is a dry system, and this can be compared with the wet suction system. In the wet suction system, as you can see on a comparison, there is, or a wet collection system, you can notice that in the wet collection system there is no orange display present here. Rather, all that is present is a water column. You can notice a clear water column. Let's just look at the two images simultaneously, and you can look at the characteristic difference between a dry suction collection system and then a wet collection system. The dry collection system will be having an orange marking, and this orange markings would not be present in the wet collection system. This is that underwater seal that I was talking about, and the intermittent bubbling of air would be present at this particular area. And in case he mentions that there is a continuous bubbling, as I've explained to you, then your answer would be continuous bubbling is due to air leak. It could indicate possibly a development of even a bronchopleural fistula. Next, we'll focus on certain definitions after the devices, and that is, he can talk about spontaneous pneumothorax, or he can talk about primary versus secondary pneumothorax. When I say primary spontaneous pneumothorax, that primary basically means that there is no defective lung tissue in this case. Like if suppose somebody is having COPD, or suppose somebody is having COVID-19, and after COVID-19 he required mechanical ventilation, and then subsequently because already his lung was injured, he developed a pneumothorax, then I'm calling it a secondary pneumothorax. If somebody is already having an intrinsic parenchymal lung disease and he ends up with a pneumothorax, I will say secondary pneumothorax. But if there is absence of an underlying lung disease and still there is a pneumothorax developing, then we call it primary spontaneous pneumothorax. Now the question in your mind would be, why is this happening? So the reason why it is happening is usually due to, DT here stands for due to, that there could be some apical blebs. There is a rupture of apical blebs. Like traditionally we read about blebs or bullas with respect to COPD, but in some patients, even if like this guy is not having COPD, but there could be presence of an apical blebs or bullas, and these apical blebs or bullas can rupture and can re-rupture as well, and thereby they can be having a recurrence of spontaneous pneumothorax as well. A large number of these patients may be a smoker. When I'm writing smoker, your query would be, sir, are you saying he's a COPD patient? No, not everybody. He might be an occasional smoker. He might be like only when he goes with his friends, no, in college, like he says, young chap, and when he goes out with his friends, that time of break, he does smoke one cigarette or two cigarettes. That's all. He's not like a chain smoker, so he's not having COPD, and he's a relatively young individual. So especially if he says a young smoker ends up with sudden onset respiratory distress, then what you need to think of is the topic of interest, primary spontaneous pneumothorax. Most of the time when I'm saying smoker, it is a reflection of a subclinical lung disease. In secondary pneumothorax, there's a full-blown clinical disease. This could be a subclinical lung disease. This history of smoker may or may not be given in a question. It could be sudden onset respiratory distress in a person, and the X-ray findings would be the ones that are shown with absence of vascular markings and hypertranslucency in the lung fields, and the lung will appear more black than normal. Primary spontaneous pneumothorax is due to rupture of the apical blebs, and therefore he will say what is the management of this condition. And here please do not answer, that's the most important part of the video now, do not answer a wide bore needle. At the moment we are not discussing tension pneumothorax. In this one I did not even say once crashing of blood pressure. I did not say pulseless electrical activity. I did not say that the person is having unrecordable blood pressure or there's like a crashing scenario. This particular person is having breathing issues, that's okay. He's having respiratory distress, so he was brought to the doctor. Doctor examined him. He did get hyperresonance in the apical lung field on the right hand side. On the right upper zone, a hyperresonant percussion note was felt. Apart from that, hyperresonant percussion note was heard, and along with that, there was even auscultatory finding. The auscultatory finding was in the form of distant breath sounds or reduced air entry. So the main message is, in this case, if it is a small pneumothorax, nothing needs to be done. But if it is a large one, and how do we differentiate between a small and a large one? Then large one will contribute to more symptoms and may even cause development of cyanosis as well. So aspiration of air, your main answer will be, it is aspiration of air. As you can see in this diagram, we are using a 50 cc syringe and we are removing the air with the help of a butterfly. We are using and removing the air which is accumulated in the chest and is contributing to respiratory distress. Because of the recurrence that can occur in these patients, he says subsequently follow-up of all of these cases should be done, and we should either be going ahead with a thoracotomy. Thoracotomy means opening up the chest, and person may not give consent for that, so we can even do a thoracoscopy, and with that would be video assisted thoracoscopy with stapling of the blebs, because they could be more than one bleb. One bleb has ruptured and the second bleb is waiting to rupture. So for the remaining blebs, which can be visualized even on a high resolution CT scan in this patient, the thoracoscopy is anyway sending in a camera into the pleural space and then going ahead and stapling these blebs. So there are three methods which have to be remembered by you for management of this condition. The most important one here is aspiration of air. Do not answer a wide bore needle. Wide bore needle with a chest tube is primary answer for tension pneumothorax. If he says primary spontaneous pneumothorax, young guy, occasional smoker, sudden onset respiratory distress with findings of pneumothorax as I explained to you, radiological ones and the clinical ones, then your answer is aspiration of air. To prevent a recurrence, we will go ahead with thoracoscopy with stapling of blebs. Another approach, he says, can be done in these patients is thoracoscopy again, but then what we are going to do is something very peculiar, that the surgeon is going to do abrasion of the pleural surface. Abrasion means that there would be rubbing of the pleural surface that would be done till it bleeds, and the reason why we are doing this rubbing of the pleural surface till it bleeds is because we want to now cause development of adhesions between the two layers of the pleura. If the surgeon is going to do this pleural abrasion means rubbing that surface of the pleura, the visceral pleura per se, and as a result of it, what's going to happen is that when you close the chest subsequently, there's going to be development of adhesions. I mean, we are causing bleeding on the surface of the pleura. So subsequently, I mean, there's going to be blood, there's going to be fibrin also present, and subsequently there's going to be adhesions developing between the two layers of the pleura, and due to these adhesions, the bullas would not be able to rupture because pleural space is obliterated after all. So, I mean, if there is no space, there would be no pneumothorax developing. As far as thoracoscopy with pleural abrasion is concerned, this is having a 100% success rate in prevention. So if he says what is the best way for prevention, and you have to select between thoracoscopy with stapling and thoracoscopy with abrasion, then thoracoscopy with pleural abrasion according to the textbook is more successful at prevention. And if he says initial management of a large symptomatic spontaneous pneumothorax of the primary variety, our answer would be given as aspiration of air. Let us now compare this with secondary pneumothorax, which you are more familiar with. Secondary pneumothorax is due to some intrinsic lung disease. It could be COPD. We saw pneumothorax in mechanically ventilated patients of COVID-19. COVID-19 will cause local damage in the lungs, and then these patients required ventilation because they were going into ARDS, and therefore, because the lung was intrinsically damaged, there were ground glass opacities, both extensive involvement of the lung, secondary pneumothorax could be a possibility. And we did have patients after COVID-19 who suddenly had a spike of their oxygen requirement, and the reason for this sudden increase in oxygen requirement was not the deterioration of COVID-19, but was rather development of pneumothorax. Let me give you one more example. It will become much more clearer to you for secondary. You are aware that Staph aureus pneumonia causes pneumatocoel formation. You know it from even your third year, that Staph aureus pneumonia, whenever they teach about Staph aureus pneumonia, they say necrotizing pneumonia damage. The damage can cause small cavities in the lung that are called as pneumatocoel. And unfortunately, if this pneumatocoel will rupture, it can communicate with the pleural space and can result in development of secondary pneumothorax. So whether he's going to talk about traditional lung diseases like the ones like COPD, COVID-19, interstitial lung disease, each one of them, or is going to talk about a much more fancier condition. This much more fancier condition also has a very long name. It's casually written as LAM, that is lymphangioliomyomatosis. And this is a condition in which there is abnormal smooth muscle growth in the lungs, and this abnormal growth of smooth muscle can cause local tissue of the lung getting damaged. The term that I've used is LAM. I'll say that once again, lymphangioliomyomatosis. The meaning of this term would be atypical smooth muscle growth in the lungs, which causes local damage to the lungs and can cause a development of pneumothorax. As far as secondary pneumothorax is concerned, in all of these cases, we will need to put in a chest tube. That would be a thoracostomy. So the main message is that thoracotomy basically means that you're opening up the chest, but thoracostomy means, stoma means creating an opening in the chest. So in all cases of secondary pneumothorax, we will need a tube thoracostomy. Now, why that is so and why aspiration of air will not be the answer here is because since these persons are having already an intrinsic lung disease, so the pulmonary reserve of these patients is lesser. I'll repeat that again. In the superior condition that I was describing, primary spontaneous pneumothorax per se, though there were some apical blebs, that is okay, remaining lung was okay, no? So I can say in primary spontaneous pneumothorax, there is normal pulmonary reserve. But in these patients, I'm putting DT due to low lung reserve. And the reason for that low lung reserve is because the lung is already damaged by conditions like asthma or COPD, COVID-19 or any parenchymal lung disease. The low lung reserve ensures that these persons will deteriorate faster, which is why in these patients, primary management would be a tube thoracostomy. Subsequently, if we are able to identify, any lesions, if any blebs can be present in COPD due to cigarette smoking, due to emphysema, then we, even in these patients, for prevention of recurrence, we might decide to go ahead with a thoracoscopy. And with help of this thoracoscopy, the stapling of the blebs would be done. So just get the words right, guys. This time I'm talking about prevention. I'm not talking about treatment. For treatment, I said tube thoracostomy is the main treatment. I mean, simple words, it means chest tube डालेंगे. Fifth intercostal space में hook it up to underwater seal. It can be dry system, it can be wet collection system. वो dry और wet system कैसे पता चलता है? वो orange वाला अगर ऐसे आपको दिखाई दे रहा है मीटर, जिसपे you can check out the readings, then it's gonna be a dry system. If it's not, then it's gonna be called as a wet system. So the difference is, this image can be given to you, dry system versus wet collection system. And then, as I explained, for treatment, it is with thoracostomy, but thoracoscopy means that you're sending in a camera. That would be video assisted VATS, video assisted thoracoscopy. And along with this, we'll be doing stapling of the blebs, and that is gonna be preventing. In fact, COPD is responsible for creation. If you listen to the emphysema video, it will become much more clear to you that a guy who's smoking all the time, pink puffer, his lungs are totally gone because elastin, which is one of the components of connective tissue, destroyed by elastase, because every puff you take, when the smoke goes in, it stimulates those alveolar macrophages. And those macrophages are going to produce elastase that's going to dissolve with the connective tissue. There's going to be a defect intrinsic in the lung, and the lung is more prone to rupture. So the main message is, to keep the long story short, guys, I can say for this slide, the minimum you are expected to remember is if there is pre-existing lung disease and there's a pneumothorax, you call it secondary. If there is no pre-existing lung disease, you call it primary spontaneous pneumothorax. Then coming to traumatic pneumothorax, it can be bullet injury, it can be stab injury to the chest, but lots of time in the exam nowadays, they would love to ask about iatrogenic traumatic pneumothorax. So one iatrogenic scenario would be that the ventilator settings are not appropriate for a person. Like in ARDS cases, we do low volume ventilation. If we keep the tidal volume at normal 12 ml per kg, the lung is going to pop off because the lung is already injured by COVID-19. So in ARDS, we always do low volume ventilation, and barotrauma due to mechanical ventilation is what is called as traumatic pneumothorax. At the moment, I'm describing iatrogenic pneumothorax. Another reason for this could be, he can say in a question, the doctor had put a central line, and the central line was maybe he was putting in jugular vein or maybe in the subclavian vein, and after that the doctor went out for a coffee, and immediately there was a call back from the nurse in the ward saying that person is having extreme breathing difficulty, lips are turning blue. So every time you read a question which begins like this and says sudden onset respiratory distress in a person after putting in a central line. Sudden onset respiratory distress can be an opening line to a large number of questions, but every time you read about sudden onset respiratory distress after central line insertion, one possibility can be air embolism. But before air embolism, what should you consider? The topic of interest, iatrogenic traumatic pneumothorax. Then every time you're doing thoracocentesis, you must always do it ultrasound guided, guys. Lots of time, radiology people will say that, okay, you can just do it without any radiological monitoring, and God forbid if somebody develops a pneumothorax, that would be taken as a medical negligence. So every time we are doing any invasive procedure in the chest, even if you are trying to do a lymph node biopsy, like this person, you are suspecting it to be granulomatous, non-granulomatous lung disease, and there are big lymph nodes in the chest. So it could be hilar lymphadenopathy, and we are trying to do a transthoracic needle biopsy. So we might end up injuring the lung tissue, and that could result in a iatrogenic traumatic pneumothorax. Every procedure that we do on the chest, which is invasive, ranging from central line insertion to thoracocentesis to a needle biopsy, is a potential for development of pneumothorax. Then as for a tension pneumothorax, I've already explained to you the keywords would be crashing of a blood pressure. He will also always talk about distended neck veins, small sign in this patient, and then he's going to talk about that absent air entry, absent bed sounds, which are one of the characteristic features, because in this condition the BP is unrecordable due to kinking of the superior vena cava and inferior vena cava, and the reason for crashing of BP is impaired venous return. That is why this is an example of obstructive shock. It is an example of pulseless electrical activity that contributes to death. And only for, I'm reiterating this once again, and only for tension pneumothorax would you be answering as putting in a large bore needle that would be put in the fifth intercostal space as compared to the second intercostal space in the mid-axillary line, and then you have to keep the needle in place, no heli transportation of a patient, and then we will have to put in a chest tube, which by deployment will again be put in the triangle of safety. And majority of MCQs that are asked in the exam will end with this particular treatment. But be wary of the fact that if he says spontaneous pneumothorax, your answer would be aspiration. If he says prevention of spontaneous pneumothorax, answer it as thoracoscopy with pleural effusion. These three concepts, guys, majority of people, what I've seen is that they fumble in the exam with respect to these three pointers. So you just need to remember which of these are to be answered in which particular scenario. Symptomatic primary spontaneous pneumothorax, no intrinsic lung disease is where you answer aspiration of air. Next up is pneumomediastinum, where the classical X-ray is given. You can see air below the heart, air outside the heart as well. So one of the classical radiological findings that you would be aware for this is called as continuous diaphragm sign. The reason why we are calling it continuous diaphragm is primarily because there is air below the heart as well. I'm not saying air below the diaphragm. That air below the diaphragm would obviously be answered as GUD, that is gas under the diaphragm, that is for pneumoperitoneum. I'm describing continuous diaphragm sign of pneumomediastinum, and one of the common scenarios that would be given to you in the exam for pneumomediastinum would be esophageal rupture. These MCQs will begin by describing an alcoholic, he's having retching and then he's having vomiting, and then it was forceful retching that caused rupture of the esophagus. So one is Boyraf syndrome, where the esophagus is the one which is damaged and the air from the esophagus will escape into the whole mediastinum. There would be chemical mediastinitis developing in this person. Other reason for pneumomediastinum can obviously be dissection of air. I mean, anytime there is a alveolar rupture, air can dissect, and air can dissect from the lungs and can go into the mediastinum. Therefore, pneumomediastinum would be developing. Sometimes it could be a possibility that there could be air dissection even from the peritoneum. So don't be surprised. I mean, the air was present in the peritoneal cavity and then through the soft tissues it can come into the chest as well. So another possibility can be air dissection. It could be from the neck. I mean, the injury could have been to the trachea and then the air will dissect into the chest. So air dissection from the neck or air dissection from the peritoneum might migrate into the mediastinum as well. Out of the three reasons that I mentioned, the most common one scenario would be given as Boyraf. Now, how would you pick this up in a question? You can go through the GI section for the same as well. I'll say the triad for it, that's called as Macular's triad. That Macular's triad will always talk about subcutaneous emphysema. Subcutaneous emphysema would be crepitus under the skin. The reason for this, I mean, traditionally we read about creps in the lung, but I'm saying crepitus under the skin. If I was talking about crepitus under the muscle, that is myonecrosis and gas gangrene. One is you read crepitations in the chest, that's like pulmonary edema. Then you read about crepitus under the skin, that is subcutaneous emphysema. Then we read crepitus with respect to muscle, and then myonecrosis also occurring, that's a feature with respect to gas gangrene. The person would be having substernal chest pain because the mediastinum and the pleural surfaces would also be involved. And the third reason, I mean the third primary pickup point in the MCQ that tells you that this is pneumomediastinum would be what I've explained to you already, that is called as Hammond sign. Hammond sign is also written in MCQs as Hammond crunch sign. I put it in bracket because if you will write that word, Hammond crunch, you would still be able to, pick up there. So lots of time in questions, he is going to write the word Hammond sign. I've also seen a couple of doctors making mistakes and mixing this up with Homan sign. Homan sign is read by you in deep vein thrombosis, where you do a ankle dorsiflexion, it causes severe pain in the calf. So remember, Homan sign is deep vein thrombosis and Hammond crunch sign is an auscultatory fending. The sound would be as if somebody is walking on snow, freshly fallen snow with leather boots on, or like when you bite into chips or wafers or crackers. I mean, that's when the crunch sound would be produced. So that is why the word was Hammond crunch sign. It is synchronous with the heartbeats. It's one of the auscultatory findings for pneumomediastinum, and pneumomediastinum can coexist with pneumothorax and vice versa. In majority of cases for the management for pneumomediastinum, your primary answer would be that you have to give high concentration of oxygen, and whatever air is present here will gradually get absorbed. So do not answer. In traditional cases, it is give high concentration of oxygen and reabsorption of air. There is no need for answering a wide bore needle or needle aspiration in this case. In fact, if this pneumomediastinum tends to occur after some coronary artery bypass grafting, if it is occurring after a median sternotomy operation, then I might have to put in a chest tube as well. But in majority of cases, there is no need for putting any drain, there is no need for any chest tube, and pneumomediastinum will respond to high concentration of oxygen as well. I mean, if it is post-surgery pneumomediastinum, things are different. But if it's gonna be like Boyraf or alveolar rupture, in majority of cases, pneumomediastinum, obviously Boyraf rupture will require surgical repair. If there's a through and through bursting of the esophagus with spilling over of spilling over of the contents of the esophagus into the mediastinal cavity, there would be chemical mediastinitis. There would be saliva, there would be alcohol that he might have consumed, there would be, intestinal secretions or even stomach acid because he was puking is escaping into the chest cavity. So there, obviously, I need to take care of the chemical mediastinitis component and the surgeon will have to handle it, and the chest has to be opened, thoracotomy will have to be done, drains will have to be done. But if he just mentions that, okay, what is management for pneumomediastinum, do not answer that wide bore needle thing. I've seen people making that silly mistake. You would be wondering, sir, that's very obvious. I understand that. But because most of the time in this topic, which is overlap from surgery, silly mistakes are made. So just need to be careful. And well, these are the details that you need to understand for this topic. So keep the pressure on, guys. Keep hammering and you'll do great in your careers.